Good afternoon, everyone, and welcome to General Session 1 of the 2022 San Antonio Breast Cancer Symposium. My name is Shom Goel. I'm a breast medical oncologist from the Peter MacCallum Cancer Centre in Melbourne, Australia, and I'm joined by Dr. Anne Partridge, a medical oncologist from the Dana-Farber Cancer Institute in Boston, and it is our distinct pleasure to be the moderators for this first session, general session of the symposium. And I can tell you it is a great pleasure to be sitting here and seeing so many members of our breast cancer community gathered together like this. So welcome to you all. This is going to be a very exciting session. There'll be 11 presentations in total, covering a range of areas from the clinical management of early stage breast cancer and advanced breast cancer, as well as questions relating to breast cancer biology. And I think we can all look forward to some much awaited data to be presented in this session. At the end of each presentation, we will have time for questions. Those of you in the room, of course, can approach the microphones, introduce yourself and ask a question, and there's also the capacity for people watching online to ask questions that way, and Dr. Partridge and myself can review those questions from the podium here. So with that introduction complete, I'd like to welcome our first presenter. That is Dr. Abdou from the University of North Carolina at Chapel Hill, who will present to us about race and clinical outcomes in the RxPonder trial, SWOG S1007. Welcome.
Thank you. Hello, everyone. I would like to thank the organizing committee for choosing our abstract for presentation today. On behalf of my co-authors, it is my privilege to present the race and clinical outcomes data from the RxPonder trial. These are my disclosures. Racial disparities in breast cancer outcomes continue to be a major healthcare challenge. U.S. Black women have 4% lower incidence of breast cancer, yet 40% higher breast cancer mortality than white women. Other studies have found that disparities persist even after adjustment for non-biological factors. We report an analysis of clinical pathologic characteristics, survival outcomes, and race in association with the recurrence score in participants from the RxPonder trial. As a reminder, the RxPonder trial established the clinical utility of the 21-gene recurrence score in patients with hormone-positive, HER2-negative breast cancer and 1 to 3 positive lymph nodes. Approximately 5,000 patients with a recurrence score of 0 to 25 were randomized to receive chemotherapy followed by endocrine therapy versus endocrine therapy alone. Results of the study showed that chemotherapy benefit differed by menopausal status. In postmenopausal women, no chemotherapy benefit was observed, whereas in premenopausal women, chemotherapy benefit was observed regardless of recurrence score. Objectives of our study included evaluating the entire cohort by race for clinical pathologic characteristics and recurrence score distribution, analyzing clinical outcomes by race using 2 endpoints, invasive disease-free survival and distant relapse-free survival, determining if race is independently prognostic, and determining whether race is predictive of treatment benefit. 18.7% of participants were excluded due to unreported race, mostly due to country-specific privacy rules. Native American Pacific Islander women were excluded from survival analysis due to small number of patients and events. Statistical methods included Kaplan-Meier graphs and multivariable Cox models with testing of the interaction of race with treatment assignment. The study included 4,048 women with known race and ethnicity. 70% of participants were non-Hispanic whites, about 6% were non-Hispanic blacks, about 15% were Hispanic, 8% were Asian, and about 1% were Native American Pacific Islander participants. These are the clinical pathologic characteristics by race and ethnicity. We note that non-Hispanic Black patients did not differ in age compared to non-Hispanic whites, whereas Asians were notably younger than other racial cohorts. Asians also had a larger percentage of premenopausal patients, whereas non-Hispanic Blacks had a lower percentage of premenopausal patients. We did not find any significant differences in number of positive lymph nodes or tumor size across all racial cohorts. Additionally, there were no significant differences in recurrence score distribution across all racial groups. Histologic grade was significantly different, where non-Hispanic Blacks were noted to have fewer low-grade tumors and more high-grade tumors compared to non-Hispanic Whites. Non-Hispanic Black patients also had higher BMI scores compared to other racial groups, whereas Asians had lower BMI scores. When looking at treatment type by white or Black race, amongst the premenopausal group, the non-Hispanic Blacks were noted to have received less anthracycline chemotherapy compared to premenopausal non-Hispanic White patients. In the postmenopausal group, there were no differences in chemotherapy received. Endocrine therapy selection was similar for white and Black race. When looking at invasive disease-free survival by race and ethnicity, we note that non-Hispanic Blacks had a 5-year IDFS of 87.2% compared to 91.5% in the non-Hispanic White cohort, with an unadjusted hazard ratio of 1.39 and a p-value of 0.04. In a separate analysis stratified by menopausal status, we see a similar magnitude of worse outcomes for non-Hispanic Blacks versus non-Hispanic Whites for both postmenopausal and premenopausal women, although no longer statistically significant. A multivariable Cox model adjusting for recurrence score, treatment arm, menopausal status, age, and grade did not alter the impact of race. We continue to note worse IDFS for Blacks versus Whites with a hazard ratio of 1.37 and a superior IDFS for Asians versus Whites with a hazard ratio of 0.67. When BMI was added to this model, the magnitude of the race effect decreases and no longer significant, but we continue to note worse IDFS for Blacks versus Whites with a hazard ratio of 1.21 and a superior IDFS for Asians versus Whites with a hazard ratio of 0.74. In terms of treatment effect, there was no significant interaction between race and treatment arm in either postmenopausal or premenopausal groups. It is important to note, however, that there were a limited number of events in the non-Hispanic Black cohort. Therefore, any apparent treatment differences by race should be considered hypothesis generating. When looking at distant relapse-free survival by white and Black race, non-Hispanic Blacks were noted to have a 5-year DRFS of 90.1% compared to 94.7% in non-Hispanic Whites, with an unadjusted hazard ratio of 1.39 and a p-value of 0.004. A multivariable Cox model adjusting for recurrence score, treatment arm, menopausal status, age, and grade did not alter the impact of race. We continue to note worse DRFS for Blacks versus Whites with a hazard ratio of 1.71. Once again, when BMI was added to this model, the magnitude of the race effect decreases, but we continue to note worse DRFS for Blacks versus Whites with a hazard ratio of 1.31. In terms of treatment assignment, 93% of non-Hispanic Blacks accepted their treatment assignment at randomization compared to 86% of non-Hispanic Whites. When looking at endocrine therapy adherence within the first year, non-Hispanic Blacks were slightly more likely to remain on endocrine therapy at the 6 and 12-month intervals compared to non-Hispanic Whites. In conclusion, non-Hispanic Black women with hormone-positive, HER2-negative breast cancer, 1 to 3 involved lymph nodes, and a recurrence score of less than or equal to 25 have worse outcomes compared to non-Hispanic White women, independent of recurrence score, treatment arm, age, and grade, although adjusting for BMI appears to decrease this effect. At this time, definitive conclusions about racial differences in treatment benefit cannot be made due to the limited number of events in the non-Hispanic Black cohort. Non-Hispanic Blacks were more likely to accept treatment assignment compared to non-Hispanic Whites and were just as likely to remain on endocrine therapy at the 6 and 12-month intervals. These data suggest that the outcome differences are less likely attributable to lack of treatment compliance within the first year. Longer follow-up and further analysis is needed to confirm this finding. For future directions, tumor biology, such as proliferation gene groups, may differ by race, contributing to the noted disparities. Future analysis of gene groups by race in RxPonder will be explored. Outcome differences may remain due to healthcare access issues, since treatment within a clinical trial can still differ across patients. Future analysis of social determinants of health based on geographic location will also be explored. We also plan to assess the likelihood of treatment completion and adherence by race and ethnicity beyond the first year. We would like to thank the patients and their support system for their participation and the study sponsors for the support of the study. Thank you.
Thank you. And now we'll take questions about Dr. Abdou's presentation. As people are heading to the mics, I'll take the chair's prerogative. As you know, IDFS includes non-breast events, and I'm intrigued by the fact that adjusting for BMI actually impacted on your hazards. How do you know these are related to breast cancer events and not some other morbidity?
Great question. So based on our IDFS event analysis, the majority of events in the non-Hispanic Black cohort were related to breast cancer recurrence, whether local, regional, or distant. And the hazard ratio did not seem to be driven by non-breast cancer related events.
Thank you. Microphone 3.
Yes, that's me, Eric Weiner, New Haven, Connecticut. I actually don't have a question. I just want to say I thought that was a beautiful presentation, and that is probably one of the most important presentations that we will hear here.
Thank you. That's an honor, Dr. Weiner.
Other questions? There's one online. Do you think that the lesser use of anthracyclines in blacks is due to the higher BMI or cardiovascular risk factors? Do you think doctors are choosing wisely with patients?
That's an interesting thought. I don't think we can speculate based on this analysis. We do not know the reasoning behind why anthracyclines were less likely given to premenopausal Black patients at this time, and whether that contributed to outcomes, but it's definitely something we're going to be looking at in the future.
Okay, another one from the virtual audience. Did you see a difference in quantitative ER or presence or absence of PR expression by race, given both are prognostic and predictive of anti-estrogen therapy?
This is something we're looking into as part of the gene groups. We haven't looked at it yet.
Thank you. Microphone 2.
I thank you. Brad Turner from Rochester, New York. I just wanted to congratulate you on your first comment on your future directions, because I think that as we look at race, quote, unquote, race, that we need to clearly look at genotype and tumor biology, so we don't look at making the same mistakes that we've done with respect to things like hypertensive treatment and GFR. So I think that's a must as we move forward, that we analyze race with respect to ethnicity, more specifically genotype as opposed to phenotype. Thank you.
Thank you for your comment.
Microphone 3.
Hi. Yeah, thanks. Andy Redfern from Western Australia. Thanks for the talk, and great to be looking at this particular question, which obviously expands the population data we know to other sort of worldwide populations more. We've had a look in Aboriginal Australians, and we saw lower compliance in endocrine treatment, but substantially higher toxicities, vasomotor symptoms and arthralgias from anti-estrogen treatments. I wonder whether you'd looked at toxicity in the between the ancestrally different populations here.
Not in this analysis. We haven't looked at toxicity yet, but there is data suggesting that there is lower adherence from with endocrine therapy in non-Hispanic blacks, but we haven't found any evidence to suggest that in our analysis yet, but our data is still immature. We only have data for the first year, so further follow-up is needed to look at compliance and toxicity.
Thank you.
And there's another question about how was race assigned? Was this self-identified? And have you, I think you said you're planning on this, but were economic factors taken into account?
Yes, race was self-identified in the RxPonder trial, and we're definitely going to be looking at social determinants of health.
Other questions? All right, and there's a question also about, for the last one, did you look at post-chemotherapy amenorrhea rates in subgroups and the OS rates, the ovarian suppression rates, and especially given the age differences?
We've discussed that, but we haven't looked at it yet. It's something we're looking at in the future.
Thank you. That was terrific, Dr. Abdou. Thank you very much.
Thank you, everyone.
We'll move on. You're next.